for me to be here in front of you. So, I am Dr. Meisha Gul, working as an assistant professor at Bahria University Dental College, Bahria University of Health Sciences. I am an ITI scholar and have recently completed my ITI scholarship from Shanghai, China. And I am also an AQ alumni. So today I am here to present the topic on computer-assisted implant surgery. Can you display my slides, please? So this is my disclaimer. Spent my entire 1 year as an ITI scholar, and this is Ninth People Hospital School of Medicine, Shanghai, China. It's state-of-the-art institute for oral implantology where cutting-edge dentistry is done using the advanced techniques like static direct surgery, dynamic navigation, and robot-assisted implant placement. I would like to dedicate my presentation to my mentor, my teacher, and my supervisor, Professor Wu, without whose support I would not be able to present in front of you. So let's start. What is computer-assisted implant surgery? As the name indicates, it's an implant placement procedure that is assisted with the use of computer. When I say computer, it means the technology, the digital technology. So why we use this digital technology in the current era? And what are the different kinds of computer-assisted implant placement surgeries? The most common we all know is with the use of static guides. As the name indicates, static means something is fixed and static, and you don't have much of the flexibility. The other kind is dynamic navigation, in which you have a flexibility to change your plan and design during the surgery. And a further advanced form of dynamic assisted implant placement is robot-assisted surgery, in which the human part is being replaced with a robotic arm. So these are the major kinds of computer-assisted implant surgery, broadly static and dynamic, and the robot-assisted is an advanced version of the dynamic navigated surgery. So as you can see in this clinical photograph and a model in which there is a static guide. Static guide is a pre-designed, customized splint that you fabricate after designing the implant in a software and you print it. Either you print it using additive manufacturing technique like 3D printing, or you can use a subtractive manufacturing technique like milling. But once you have this guide, you can see that there is a specific hole inside it. This is a metal sleeve. You use this, it will help you to guide your drill and the implant to your desired position. The desired position is the one you have already designed in the software. Just like this, you place your design guide in the mouth and you need to check whether it's stable or not. Once you place it in the mouth, you use a sequence of drills, and these drills will take the path that is defined by this sleeve. You don't have the opportunity to move or change the direction of your drills and the position of your drills during the surgery. That's why we call it as static, because you don't have much of flexibility to change your position during the surgery. And once you place it, there is certain limitations to this kind of surgery. As you can see, there's only one point of entry and exit. This is not freehand, right? So you cannot change your design. If something happens, for say you need to place bone graft, there's a huge defect, you are working on a site that is very near to a vessel, because sometimes what happens is some things are different when you design it on the CBCT and you actually do the surgery. So if you see there's a complexity and you want to change plan, you cannot do it in case of static guide because it's fixed and either you use it or you don't use it. It's like that. The other limitation is as it's restricted opening, so the cooling effect is a bit compromised, so there is more chances of heat generation during the surgery. And the other thing, if the patient has limited mouth opening and you're working in a posterior site, the patient mouth opening is limited, so you will be in trouble, you will not be able to use it properly. And the other thing is the cost involved in the fabrication of this guide. So these are the certain limitations associated with this kind of surgery. Although for simple cases, it's very accurate, it's very precise, and it all depends you design on the CBCT. As compared to the static guide, the dynamic navigation system, you don't need a physical guide. So you can do it just like you do freehand, just you need a handpiece and the drills. But we basically place a tracking device in which the position of the patient, the movement of your instrument, and everything is tracked by a software. So it's like a tracking device attached to it. And then it will provide you real-time guidance. If you deviate from your path, it will guide you that you are deviating in any direction, either it's mesiodistal, facial-lingual, that in any ways it will direct you to your correct position during the surgery. And you have the flexibility to change your design during the surgery. This is the major advantage of a dynamic navigation system. Although how this process works, I will go into the detail in further slides, and I will discuss the workflow, how you're going. I would like to make you understand more by giving you just a simple example. So you have two photographs here. One is you can see it's like a tunnel. So this is an example of a static guide. So if you want to reach a destination, one is you undergo a bypass, like underpass or a tunnel like this, and you have an open road in which you can use your Google Maps. Every one of us use Google Maps nowadays. So if you enter into a tunnel, you have just one point of entry and one point of exit, and if there's something happens in between, with blockage area, any restriction, you won't be able to change your direction from right or left or anywhere. You need to just go straight whatever path is designed by this tunnel, right? So this is just similar to the static guide. Whereas the other example that depicts how the dynamic navigation works. We use Google Maps in everyday life. So nowadays you see that roads are under construction, there's frequent blockages anywhere. So you want to reach destination from point A to B. There is some, so you can change your right and left, and you can then and then you can reach your destination. So you have a flexibility. So you can take this example to understand how dynamic navigation works, because all these maps are navigation devices, right? Example, so you can correlate with the navigation surgery as well. So why we need to use these kind of surgeries, why to use such technology, such costly treatments and everything? We want an accurate and precise treatment for our patients. We need to quality of life of our patients. Everyone can place implant. Implant placement mushkil nahi hai, just drill and just place it. But you need to make it functional, right? If the prosthesis is not functional, it's not worth it in placing an implant in that patient. And especially it's very important in cases of complex surgeries and trauma cases, where you have limited bone support, you're working in an area where it's very near to the vital structures like nerves, vessels, sinuses, and even a millimeter of an error can end up in a big error. So you want to be as much accurate as possible. And with the use of this technology, we can be as precise as possible. We can plan everything before the surgery, and then we can just execute it according to our plan. And then in that term, the surgery will be very efficient, it will be very accurate, and it will be safer for our patients. So the three major and big advantage of using this surgery is the efficiency, the precision it provides, and the safety. So you need to think about, and in everyday life, if you don't learn about the technology, we'll be like. So I will just go through the steps and then I'll come to this slide. So the workflow was, it will start with the CBCT of the patient. Then we place this registration device along with the markers and advise the patient to take the CBCT scan. We upload this data into the designing software. We design our implant position, and all the planning is done on this navigation software. After this, we need to register and calibrate our instruments like the drills and the handpiece into the software using this positioning device. And then we need to fix this positioning device in the oral cavity. So this is the positioning device, and it has markers on it so that the device can detect the patient, the position, and the instruments as well. After placing the splint in the oral cavity, we need to again calibrate these markers so that it will register the anatomical area where we are going to work. So this will align the patient actual position to the one we have designed in the software. So it will align both so that it can direct our surgery and we can place the implant according to the desired plan, whatever we have designed in the software. After this, as an immediate implant placement case, we do the immediate extraction. That should be as atraumatic as possible. And then after the extraction, you need to evaluate whether the buccal plate is intact or not. If it is damaged and if there is an extensive damage, you cannot proceed with the surgery. You have to stop, you place the graft and close it. If there is a minor defect, still you can proceed with the surgery. The registration device is fixed in the oral cavity, and then you can start the surgery. As you can see in this screen, this is the software and the planning software. You need to position yourself in the center. Once you deviate in any direction, mesial, distal, buccolingual, this circle will turn red, and then it will direct you that you are moving in a wrong direction, come to the center. So your position, your angulation, everything is guided, and this bar shows the length of the implant. From 0 millimeters up to the length, if you are placing a 12 millimeter implants, it will direct you. Once you reach the desired length, it will turn red. You need to stop over there. So during the surgery entirely, you will be guided by this software. After the placement, you need to check the primary stability. There are various methods to check whether your implant is stable or not. So this is one of the techniques. Using the implant stability quotient, ISQ value, that should be 70 or more in terms of immediate implant placement. We want to proceed with the prosthesis as well, or the loading. For immediate implant placement, always you need to be slightly away from the buccal bone plate. So this is called as the jumping distance. So it should be ideally more than 2 millimeters or at least 2 millimeters. If you just place the implant along with the buccal bone, there's high chances that it will get resolved over the follow-up period and the aesthetic outcome will be worse. So this jumping distance is filled with the bone graft, and then you close it. This is very important. Once the surgery is done, you need to check whatever you have done is quite accurate. So you check the accuracy of your placement. So your post-operative CBCT is aligned with your pre-operative design, and then you check how much accurate you were. So as you see the reading at different levels, like the platform, apical and angular deviations, the platform and the apical deviations are within 1 millimeter. That is quite accurate. And the angular deviation is less than 5 degrees, which is also acceptable. This is the post-operative radiograph. We immediately take the oral scan of the patient and then provide him a temporary prosthesis, which the patient wears for at least 3 months. After 3 months, when we remove it, we have a soft tissue profile like this, and it's quite suitable now, so we can proceed with the permanent prosthesis. We again take the intraoral scan, and this is the final outcome. So this is a zirconia crown and a screw-retained prosthesis. We usually prefer a screw-retained crown because it is easier to maintain, and the aesthetic outcome was really good and the patient was quite satisfactory. This is the final radiograph. So I'd like to discuss a few pointers about this. Whenever you choose type 1A protocol, that is immediate implant placement and immediate loading, there are certain factors that you need to consider. The patient should be a healthy non-smoker with no acute infection like periodontal disease. The occlusal schemes should be favorable. There should be no parafunctional habit or anything that will interfere after you load the prosthesis, because you're doing an immediate restoration as well. The facial bone ideally should be intact. There should be no endodontic infection, and there should be enough apical bone to reach the primary stability. If you are not able to achieve primary stability, you cannot do the immediate implant placement. If the soft tissue quality is thin, you will consider about doing a soft tissue grafting as well, or bone grafting sometimes if there's a small defect there. Flapless approach is the best approach in which you get the maximum aesthetic outcome, but if you want to raise the flap, you can do it, but very conservative. During the extraction, you need to be as atraumatic as possible, and there should be a facial jumping distance as I have mentioned earlier. And the primary stability is the most important factor. So immediate implant placement is a predictable option in all the patients, and nowadays we try to do immediate implant in almost all the cases except for very few. As I have already mentioned, the criteria you need to evaluate before planning for immediate implant placement. Although type 1A protocol is a complex procedure, you always need to advise patient that there is chances of biological and prosthetic complications, because everything cannot be 100% correct. So there can be some complication as it's a complex procedure, even if it's a single implant placement. So you need to be very careful in your planning. You need to have proper designing softwares you need to plan beforehand before proceeding for the surgery. And whenever you design a prosthesis, you need to consider certain things. Your prosthesis should be highly polished. The provisional restoration and the occlusion, you cannot make any eccentric contacts on your prosthesis. Even the proximal contact needs to be very light. If there's a very tight interproximal contact, it can also load your implant and disturb the healing process. So your occlusion, your quality of the prosthesis should be highly polished, and you should either place it immediately or within few days. And ideally it should be screw retained, but sometimes you have, if the angulation is not correct, you also go for the cement retained prosthesis as well. So if you want to compare the different kind of computer-assisted surgeries, starting from the static, moving to the dynamic navigation and a more advanced robotic-assisted surgeries, the major difference is that in static you need a physical guide, but in the dynamic navigation or robot-assisted surgery you don't need a physical guide. The guide is virtual, it's just the software, but it will need to have an additional cost and the expertise, and there's a learning curve to it. So every need, like for say you need to practice on models for 20 or more times to get used to it. It's just like the games. Whoever is very good at playing video games, they can easily perform these kind of surgeries. And the other thing is the flexibility and the real-time guidance, which is absent in static surgeries as compared to the dynamic and the robot-assisted surgeries. So in the end, this is just a 1-minute video for robot-assisted implant placement. So I would like to play this. So could you please play this video? There's some error in playing the videos as well. It cannot be played. Okay, fine. So we can have it some other day when the technology will support us more. Thank you for your time. If you have any questions, so we can have it. Thank you so much.